In our previous sketch, we covered two of the four major types of shock: hypovolemic and distributive. This time we'll finish up our discussion of shock by covering the other two: cardiogenic and obstructive shock. Are you ready for the epic finale in the Shock Force cinematic universe? In this thrilling installment, Cardio Man and Captain Shield fight and obstruct their way into Hypoxosis compound, the heart of evil. As you might remember from part 1 of this series, Cardio Man and his cracked heart reactor represent cardiogenic shock, while Captain Shield and his trusty lightning shield represent obstructive shock. Let's kick off this final battle by looking at Cardio Man. Cardiogenic shock results from intracardiac causes of pump failure, which is why Cardio Man is fighting inside the fenced area of Hypoxosis compound. As you might expect, pump failure of any sort leads to decreased cardiac output, hypotension, and shock. The different causes of cardiogenic shock are broken up into three major categories: cardiomyopathic, arrhythmic, and mechanical. The first type of cardiogenic shock, cardiomyopathic, is caused by impaired myocardial function. To remind you that cardiomyopathic cardiogenic shock is caused by impaired heart muscle function, just check out this drone Cardio Man is fighting. Its muscle fibery arm is all broken. Way to go, Cardio Man. Another heart muscle bites the dust. Causes of cardiomyopathic cardiogenic shock include MI, severe dilated cardiomyopathy, or myocarditis. These conditions all cause intrinsic death or damage to the myocardium and limit the heart's ability to contract, which can then lead to shock. The second type is arrhythmic cardiogenic shock, which, as its name suggests, is caused by rhythm disturbances significant enough to impair cardiac output and result in shock. Arrhythmic cardiogenic shock is represented by the second defeated drone writhing and shaking after being terminated by Cardio Man's hand missiles. Typically, the arrhythmias that are significant enough to cause cardiogenic shock include third-degree AV block or sustained ventricular arrhythmias like VTAC. Bottom line, these arrhythmias have to be pretty severe to produce enough of a drop in cardiac output to cause cardiogenic shock. Lastly, the third type of cardiogenic shock is mechanical, which is caused by damage to the structures of the heart other than the myocardium. To represent mechanical cardiogenic shock, take a look at this last massacred drone with parts flying off of it. That big gaping smoking hole? Courtesy of Cardio Man. The most common cause of mechanical cardiogenic shock is severe valvular insufficiency. Hence that valve flying off the broken drone. For more details on the different types of valvular insufficiency, check out our aortic valve disease, mitral regurg, and tricuspid regurg sketches. Great! Now that you're up to speed on the different types of cardiogenic shock, let's talk about its presentation and workup. Just like all the other types of shock, the presenting history in cardiogenic shock can vary widely since there are many different underlying etiologies. While you should be aware of the other causes we've mentioned, the most common cause of cardiogenic shock, by far, is myocardial infarction. At Sketchy, MI is represented by our recurring symbol, the heart-shaped guitar with broken strings being played by Cardio Man's intern. Not off to a great start, kid. Also, you know you're in the middle of a war zone, right? That's fine. You know what? Do your thing. While myocardial infarction is most commonly thought of as a cardiomyopathic cause of cardiogenic shock, the complications of MI, such as papillary muscle rupture or third-degree AV block, can also cause mechanical or arrhythmic cardiogenic shock. For more info on the clinical presentation of acute MI, check out our sketches on acute coronary syndrome. When it comes to the objective findings of cardiogenic shock, many of the exam findings and lab results you'll commonly see are common to all types of shock, including tachycardia, tachypnea, altered mental status, oliguria, and anion gap metabolic acidosis. For your sanity's sake, we won't rehash these findings again here. Instead, let's take a look at some of the findings that are unique to cardiogenic shock. Since we're talking about pump failure, it kind of follows that cardiogenic shock often presents with signs of acute decompensated heart failure, represented by our recurring sketchy symbol, the floppy heart balloon. Yep, that's hypoxos. Ruining children's lives one deflated balloon at a time. The man's sick, I'm telling you. The findings of acute decompensated heart failure you'd expect to see on physical exam include pulmonary edema, represented by our recurring sketchy symbol, the wet lung-shaped bulletproof vest on that guard, and elevated JVP, represented by those big dilated blue necks on his guns. See those murmur lines emanating from the valve flying off this defeated drone? That's to remind you that murmurs are frequently heard in mechanical causes of cardiogenic shock. Whether it's acute mitral regurg from papillary muscle rupture, acute aortic regurg from retrograde aortic dissection, or a number of other causes, a new murmur in the setting of shock is strongly suggestive of mechanical cardiogenic shock. Since the most common cause of cardiogenic shock is MI, if you suspect that your patient is presenting with it, a workup for ACS should always be done. That means getting cardiac enzymes like troponins, represented by a recurring sketchy symbol, the T-bone steak. Easiest way to subdue an attack dog. Way to go, kid. I take back what I said about you earlier. We've mentioned that cardiogenic shock can present with symptoms of acute decompensated heart failure. Well, the converse is true too. Severe acute decompensated heart failure can also lead to cardiogenic shock. In these cases, cardiac biomarkers of heart failure will be present, such as elevated BNP, represented by the souped up BNP defense blimp patrolling the grounds of hypoxosis layer. I don't think a T-bone steak will subdue that thing. See those banners marking hypoxosis territory? There are recurring sketchy reminders to order an ECG and chest x-ray if you suspect cardiogenic shock. These tests will provide you with more evidence supporting cardiogenic shock, such as pulmonary edema or a widened mediastinum in the case of the chest x-ray, or clues to the underlying etiology, such as ST elevations or VTAC in the case of the ECG. The imaging test of choice for patients with suspected cardiogenic shock, however, is the echocardiogram. Echocardiography, represented by a recurring sketchy symbol, the heart-shaped megaphone, can both provide evidence to diagnose cardiogenic shock, such as poor LV function, and identify some of the underlying causes, such as valvular or septal abnormalities. Finally, remember those pulmonary artery catheter measurements we went over in part 1? It's a pretty safe bet you'll be asked about them at some point, whether it's on the wards or, more likely, on the exam. The characteristic pattern of PA cath values in cardiogenic shock are a decreased cardiac index, increased systemic vascular resistance, increased pulmonary capillary wedge pressure, and decreased mixed venous oxygen saturation. Let's summarize the clinical presentation of cardiogenic shock in a sample assessment statement. Ms. Ironheart is a 64-year-old woman with hypertension, diabetes, and hyperlipidemia presenting with exertional chest pain and shortness of breath for the past 3 hours. Sublingual nitroglycerin has not relieved her symptoms. Vitals are notable for a BP of 84/52, heart rate of 132, and respiratory rate of 22. On exam, she appears in distress, with inspiratory crackles on lung auscultation. ECG reveals ST elevations in leads 2, 3, and AVF. Chest x-ray reveals bilateral infiltrates consistent with pulmonary edema. Given these findings in the context of Ms. Ironheart's symptoms, I'm most concerned for cardiogenic shock secondary to inferior wall STEMI. Yikes. Miss Ironheart doesn't sound like she's doing so well. What can we do for her? As we've mentioned in previous sketches on shock, always begin by stabilizing your patient's airway and breathing. However, once it's time to stabilize circulation, that's when the plan for cardiogenic shock starts to deviate from those other types of shock. IV fluids will still be a component of circulatory support, which is why we've brought back our shock force intern filling up the ABC electric truck with fluids. However, since the underlying problem is not a volume deficit, IV fluids should be used very judiciously. Hence the do not top off sign on the door of the truck. Aggressive IV fluid resuscitation can actually be harmful in patients with cardiogenic shock since the extra volume exacerbates fluid overload and worsens pulmonary edema. That's why it's important to start resuscitation with small volumes of IV fluids if you suspect cardiogenic shock. There is one important exception to the slow fluids rule in cardiogenic shock, however. When right ventricular infarction leads to cardiogenic shock, aggressive IV fluid resuscitation is actually indicated since the increased RV filling pressures that result are necessary to maximize flow to the left ventricle. That's why there are a bunch of fluid canisters next to this keep right sign. Bottom line, if you suspect cardiogenic shock, start with small amounts of IV fluids, assess for improvement, and keep going only if it's actually helping. So, if we don't use IV fluids for the majority of patients with cardiogenic shock, how do we stabilize their circulation? You got it, vasopressors. Vasopressors, represented by that air compressor filling up the red flat tire on the ABC electric truck, is the first line therapy for circulatory support in cardiogenic shock. The most common vasopressors used in the management of cardiogenic shock include norepinephrine and dopamine. Additionally, dobutamine, which is technically not a vasopressor as it's an inotropic agent that actually causes vasodilation at low doses, can also be used, often in conjunction with norepinephrine, to offset the aforementioned vasodilation that can occur. Once you've stabilized the patient, the next step is to treat the underlying cause of cardiogenic shock. That's why we've included this other intern working on the underbody of the shock 4 support truck. These therapies can range from coronary revascularization for acute MI, to cardioversion for VTAC, to emergent surgery for aortic dissection. For more details on the management of the various causes of cardiogenic shock, head over to our sketches dedicated to these conditions. And that's about it for cardiogenic shock. It looks like Cardioman's doing just fine blasting his way into Hypoxos's lair. Let's leave him for now and check in with Captain Shield, our Shock 4 superhero representing obstructive shock. In contrast to cardiogenic shock, obstructive shock, represented by the captain's signature lightning shield, results from extra cardiac causes of pump failure, which subsequently lead to decreased cardiac output, hypotension, and shock. That's why Captain Shield is running outside hypoxosis fenced compound. Just like cardiogenic shock, the causes of obstructive shock can be further divided into two categories: pulmonary vascular and mechanical. Most cases of obstructive shock fall into the first category of pulmonary vascular disease. These conditions, such as pulmonary embolism and severe pulmonary hypertension, are characterized by significantly increased pulmonary vascular resistance, represented by our recurring sketchy symbol, the tight red laces on pulmonary witch's corset. The result of these conditions is right ventricular failure, as it's unable to generate enough pressure to overcome that super high PVR. Hence the tear in pulmonary witch's heart-shaped cape, conveniently located on the lower right side. Anatomically correct, buddy. The other category of etiologies of obstructive shock, mechanical, is characterized by mechanical restriction of cardiac filling. Just imagine the heart looking kind of like that heart-shaped grenade in Heartlock's hand. These conditions, which include tension pneumothorax, cardiac tamponade, constrictive pericarditis, and restrictive cardiomyopathy, cause decreased cardiac output through decreased preload rather than pump failure. The end result, though, is still the same: obstructive shock. Looks like this fight's heating up. Let's take a couple of minutes to dive into the causes of obstructive shock a little further, so you'll know what clues to hone in on that'll push you towards a diagnosis of obstructive shock. The most common cause of obstructive shock overall is pulmonary embolism, represented by our recurring sketchy symbol, the bird's nest obstructing the leaves of that lung-shaped tree. Patients with PE will also present with symptoms such as hemoptysis and leg swelling, along with the historical factors of Virchow's triad: blood stasis, endothelial injury, and hypercoagulability. In addition to pulmonary embolism, straight-up pulmonary hypertension, if severe enough, can also cause obstructive shock. At Sketchy, pulmonary hypertension is represented by a recurring symbol, the stretched red net, this time tied around this hostage's chest. Guess that guy didn't read the book on how the good guys are supposed to win this fight. As for the mechanical causes of obstructive shock, two of the most common causes in this category include tension pneumothorax, represented by the broken mast with collapsed sail on this sailboat pushing towards the side with the good sail, and cardiac tamponade, represented by the heart-shaped grenade being squeezed by heartlock. These two conditions are the most common mechanical causes of obstructive shock because they can be caused by trauma to the chest, which is why we've drawn our recurring sketchy arm cast on this soldier being taken out by the captain's lightning shield. Lastly, two of the least common causes of obstructive shock include constrictive pericarditis, represented by the rope tied around that heart-shaped post, and restrictive cardiomyopathy, represented by heartlock's, heart locked inside that red mesh cage. If only someone could get inside and soften that thing up a bit. Unlike the rest of the causes of obstructive shock we've discussed, constrictive pericarditis and restrictive cardiomyopathy are more chronic conditions, so look out for a longer timeline of symptoms. To learn more about each of the different causes of obstructive shock, check out our dedicated sketches on those conditions. Once again, obstructive shock will produce a number of objective findings that are common to all types of shock. Head back to part 1 of this series if you need a refresher on them. Instead, let's take a look at the findings unique to obstructive shock. We'll start with a familiar finding, but with a twist. Now, why would they place a guard by that tree? Could it be that there's some secret, poorly guarded backdoor to Hypoxos's lair? Come on, you're kind of giving it away there, soldier guy. Anywho, can you spot the differences between this soldier and the one we saw earlier? The dilated blue gun necks are still there, which should remind you that, like cardiogenic shock, elevated JVP and dilated neck veins are also seen in obstructive shock. However, signs of pulmonary fluid congestion, such as crackles from pulmonary edema, should be absent. That's why this soldier is not wearing a wet, lung shaped bulletproof vest like his friend over there. Not sure it was all that effective anyway. When you suspect that your patient might have obstructive shock, the tests you'll order are directed primarily at identifying the underlying cause. An ECG can help you diagnose two common causes of obstructive shock: PE and cardiac tamponade. Signs of right heart strain, like the classic S1Q3T3 pattern, can point you towards PE, whereas electrical alternans can suggest cardiac tamponade. It's important to remember, though, that while these findings may be specific, they're not sensitive. The chest x ray in patients with suspected obstructive shock is most helpful in diagnosing tension pneumo. Look for absence of lung markings over the affected side and tracheal deviation towards the unaffected side. Rarely, you might also catch a glimpse of the classic water bottle cardiac silhouette that can be seen in patients with cardiac tamponade, but don't hold your breath on that one. Much more commonly, if your patient has obstructive shock due to cardiac tamponade, you'll make the diagnosis with an echocardiogram, represented by our recurring sketchy symbol, the heart-shaped megaphone. The echo is the imaging modality of choice if you suspect your patient may have obstructive shock, as it can identify features of tamponade, constrictive pericarditis, restrictive cardiomyopathy, and even right ventricular strain suggestive of pulmonary hypertension or PE. Last but not least, let's recap the classic PA catheter measurements in obstructive shock that we reviewed in part 1 of this series. 3 of the PA cath values in obstructive shock are pretty straightforward: decreased cardiac index, increased systemic vascular resistance, and decreased mixed venous oxygen saturation. When it comes to pulmonary capillary wedge pressure, though, obstructive shock gets a little tricky. In pulmonary causes of obstructive shock, such as PE, pulmonary hypertension, and tension pneumothorax, the pulmonary capillary wedge pressure will be normal or low. In cardiac causes of obstructive shock, such as cardiac tamponade, constrictive pericarditis, and restrictive cardiomyopathy, the pulmonary capillary wedge pressure will be increased. All right, let's summarize the prototypical presentation of obstructive shock in a sample assessment statement. Crabman is a 57-year-old man with a history of hypertension and colon cancer, presenting with acute onset of chest pain and dyspnea. Vital signs are notable for a BP of 80/40, heart rate of 140, and respiratory rate of 35. Physical exam is notable for respiratory distress, elevated JVP, and cool extremities. The ECG shows nonspecific ST segment abnormalities, and chest x-ray is unremarkable. Given Crabman's cancer history, I suspect he may be in obstructive shock secondary to acute pulmonary embolism. Woo! But dude, don't pat yourself on the back just yet. Now you gotta treat this bad boy. First things first, as with any type of shock, your first step is always to stabilize the ABCs. The management of obstructive shock is actually quite similar to that for cardiogenic shock. So let's head back over to the ABC electric truck. As with cardiogenic shock, IV fluid should be used judiciously in patients with suspected obstructive shock, as too much fluid can overload the obstructed or restricted heart and make the situation even worse. However, since decreased preload is the underlying pathophysiology of the mechanical causes of obstructive shock, fluid resuscitation can be helpful. Just start with small amounts and reassess frequently for response to therapy. As you might imagine, patients with obstructive shock may also benefit from vasopressors to increase cardiac output if their hypotension doesn't respond to IV fluids alone. As with cardiogenic shock, the most frequently used agents include norepinephrine, dopamine, and dobutamine. The rule of thumb is to use as low of a dose as possible that will restore tissue perfusion, gauged by mental status, urine output, or mean arterial pressure, back to normal. And finally, once your patient's airway, breathing, and circulation have been stabilized, pivot immediately to the diagnosis and treatment of the underlying cause of obstructive shock. This can include thrombolysis for patients with PE, needle decompression and tube thoracostomy for patients with tension pneumo, or pericardiocentesis in patients with cardiac tamponade, among other interventions. For more details on the management of these and other causes of obstructive shock, check out our sketches dedicated to them after you're done here. Let's wrap up this final battle with a brief review of cardiogenic and obstructive shock. Cardiogenic shock results from intracardiac causes of pump failure and can be divided into cardiomyopathic, arrhythmic, and mechanical causes. The most common cause of cardiogenic shock is myocardial infarction and its many complications. Unsurprisingly, patients with cardiogenic shock frequently present with signs and symptoms of acute decompensated heart failure, such as pulmonary edema and elevated JVP. A new murmur in the setting of shock should raise red flags for mechanical cardiogenic shock, such as acute MR from papillary muscle rupture or an acute AR from retrograde aortic dissection. Common tests you'll order to help you diagnose cardiogenic shock and identify the underlying etiology include ECG, chest x ray, and echocardiography. The characteristic pattern of PA cath values in cardiogenic shock are a decreased cardiac index, increased systemic vascular resistance, increased pulmonary capillary wedge pressure, and decreased mixed venous oxygen saturation. When it comes to management of cardiogenic shock, the most important thing to remember is to take it easy on the IV fluids, lest you overload the ailing heart and make things worse. Unless you know for sure that your patient is suffering from a right ventricular MI, IV fluids won't reverse the hypotension of cardiogenic shock. Instead, you'll rely a lot on vasopressors, including norepinephrine, dopamine, and dobutamine. Once you've stabilized the patient, the next step is to treat the underlying condition. Obstructive shock, on the other hand, results from extracardiac causes of pump failure. Most cases of obstructive shock are due to pulmonary vascular causes, such as PE and severe pulmonary hypertension. Mechanical causes of obstructive shock also exist and include tension pneumothorax, cardiac tamponade, constrictive pericarditis, and restrictive cardiomyopathy. Since both cardiogenic and obstructive shock are heart-related causes of shock, the diagnosis and management of the two are very similar. ECGs, chest x-rays, and echoes are used to diagnose obstructive shock and identify the underlying etiology. Once you've made the diagnosis, treatment is virtually identical. Judicious use of IV fluids and vasopressors to stabilize the patient's circulation, then diagnosing and treating the underlying cause of obstructive shock. Boom! Say goodbye to hypoxos because the shock force are victorious once again. Time to jump out of this universe once and for all. Shock force disassemble.